All right, so let's transition now to newly diagnosed advanced ovarian cancer. And unfortunately, that's how we as oncologists and gynecologic oncologists spend most of our time. I think it's no secret that most patients with ovarian cancer are diagnosed at stage 3 and 4, that their risk of recurrence is high, but it is our largest opportunity for cure. And so I want to spend a significant amount of time on what's the appropriate frontline treatment. And surgery has a role, and there's been this controversy, well, maybe surgery should be done in the beginning, a primary debulking, or it should be done after 3 cycles in the neoadjuvant setting. And Tom, at ASCO 2018, there was another study looking at neoadjuvant chemotherapy and interval debulking. Can you summarize those results for us?
Yeah, the Japanese group did a study looking at upfront primary debulking versus the neoadjuvant approach, as you said, in stage 3-4 ovarian cancer patients. And what they found was that the median overall survival was 49 months in the primary debulking group and 44 months, 44.3 in the neoadjuvant group. But the hazard ratio was 1.052, so the curves were apart at the median, but the overall assessment showed no difference. It did cross 1, so because of that, they said they couldn't reject the non-inferiority. But it's sort of a statistical conclusion of this study, and non-inferiority studies can be difficult, and you often require more patients for a non-inferiority study. And this particular trial only had 301 patients, so it was probably underpowered to fully reject. And I think that that's really what was going on there.
So not a practice changing, neoadjuvant chemotherapy is here to stay.
I think the practical, with a hazard ratio of 1.052, which was below their threshold that they wanted of 1.16, says that while we can't officially, statistically reject non-inferiority for neoadjuvant, it is reassuring that the hazard ratio is 1.052, and it fits with the other data sets now that we have from Chorus and from the EROTC study that suggests that there is no difference. But there's still those that strongly believe in primary cytoreduction in this country.
So I think that we would agree that the best opportunity is the surgery in the beginning and that the goal is complete resection. But there are some patients where that's probably not the right path forward. You mentioned the New England Journal of Ergo-EORTC and the Lancet Chorus paper. Katie, who is the right patient for neoadjuvant chemotherapy and interval debulking? In other words, who would you not do primary debulking on?
That's the $1,000,000 question.
That's why I asked you.
I know. Before I answer that, the other thing I want to point out about this study is just like the other two, the primary cytoreduction rate of getting to no gross residual was incredibly low. It was 10%. So that's the other thing we have to keep in mind. In the primary debulking.
Yeah, I know.
And only 30% interval debulking. So once again, we have this population that really didn't get to the surgical endpoint that we're trying to get to.
They're Japanese. They have wonderful knives. I don't know what you're talking about.
Well, but I do think it speaks to the fact that probably there's patient selection on who the surgeons, because these are good surgeons in all these countries, who they didn't mind not operating on. So there's a gestalt that we have when you look at a patient. There's the obvious things, someone that's too sick for surgery,
too sick,
and that's what we're not talking about.
Right. Should have
Number
neoadjuvant.
one, right, who it should have neoadjuvant. And then there's kind of the 2 criteria. One is likelihood of getting to no gross residual, and how you assess that via laparoscopy with various scoring systems. FACOG is the most widely published. Imaging, there's multiple ways to look at that and what you call not debulkable. So there's that group, and if you, with an expert surgeon, think I cannot get that to no gross residual, that's someone who needs to go to neoadjuvant chemotherapy. And then the second group is the group of patients for whom you look at it and you say it's going to require this to get 2 bowel resections and a splenectomy to get this out, but her risk of major morbidity is excessive. And again, there's multiple scales for that. Aleti has published a nice one that's referenced often, that if you have a risk score over 3, it's like an 80% risk of major morbidity. So those patients should be treated. That's kind of the 2 sick cohort,
sort of. I mean, there's an overlap. So
there's some overlap there.
But I think the most difficult question in my mind is who should have neoadjuvant chemotherapy and interval debulking versus primary debulking. And whatever that means, the sick patient shouldn't have primary debulking, should have neoadjuvant. And whatever that means, the patient who you think you can't cut the cancer out shouldn't have it. So should we do laparoscopy? I really want your two opinions. Is looking in there and going, oh, I don't want any part of that? Or can you just look at the CAT scan and 10 societies and a high C125 and move on?
I think it depends. So you can get your medically unfit question
Yeah, that's
clinically
easy.
in the office. The CT can tell you, do I have portohepatus disease? Do I have small bowel mesenteric retraction? Do I have significant disease? It can tell you so much. And then you'll still have this group of patients where you just don't know. And so to me, laparoscopy is useful in those patients where you still don't have, you haven't met your criteria yet.
So Oliver, do you do laparoscopy occasionally?
Yes, I do.
How often? Is it because you cut out no pun intended, you exclude the medically infirm. There is a group of patients where you look at the CAT scan, this isn't going to work. How often do you get to that laparoscopic assessment?
About half of the patients that I suspect have ovarian cancer would undergo laparoscopy. I also have to say that laparoscopy at times does not give you the entire picture, and it still at times requires a laparotomy, at least a small incision to evaluate the peritoneal cavity.